Hello, my name is Kaylee Wolf, and I'm a graduate student in the nursing program at the University of Southern Maine. Today, we're going to talk through a case study focused on treating erectile dysfunction in primary care settings. So, let's meet our patient. His name is Raymond Barrett, and he's 62 years old. Mr. Barrett identifies as a cisgender male. His past medical history includes hypertension, hyperlipidemia, and he's status post a remote appendectomy as a teenager. He is married with 3 grown children, and he has smoked 2 packs per day for 46 years. He also endorses drinking 2 to 3 beers per day. Mr. Barrett presents today for his annual physical. His vital signs are largely unremarkable. However, we do note an elevated blood pressure at 140/85. His current medications are 20 milligrams of lisinopril daily, 40 milligrams of atorvastatin daily, and he takes a daily aspirin to address a 10-year cardiovascular risk of 43%. Mr. Barrett also tells us that he recently started taking a daily multivitamin, probiotic, and fish oil supplement to appease his wife. He says she's on a health kick. During our subjective assessment, we do note some changes since last year. Mr. Barrett tells us that his youngest daughter recently left for college, so he and his wife are adjusting to life as empty nesters. And he's also looking forward to retiring from VIW in 3 years. He tells us that despite his elevated blood pressure in the office this morning, his at-home blood pressure readings are usually within his goal range of being less than 130/80. And this is consistent with some known white coat anxiety that we've observed in previous visits. He tells us that he's not here for any particular reason, just coming in for a checkup. Moving along with the physical examination, we find that Mr. Barrett appears to be in pretty good shape. No major concerns arise here. But then, after this pretty uneventful checkup, we get a classic doorknob question. Just as we're looking to leave the room, Mr. Barrett chimes in and says, "Oh, by the way, there's just one more thing I wanted to ask about. Lately in the bedroom, things haven't been so good. I see the Cialis ads on TV, but I hear it's expensive. Is there a generic? My buddy is trying DHEA, and he thinks it's helping a little." This question leads us into a discussion of erectile dysfunction in primary care settings. So, what is erectile dysfunction, or ED? UpToDate defines it as the consistent or recurrent inability to acquire or sustain an erection of sufficient rigidity and duration for sexual intercourse. It's important to note that ED is just one aspect under the larger umbrella of male sexual dysfunction, which includes other concerns such as premature ejaculation. So, given that Mr. Barrett has been a little bit vague about saying things aren't great in the bedroom, we would want to ask some more questions to make sure that we're actually talking about ED and not potentially some other type of male sexual dysfunction. ED is a common condition. An estimated 18 to 30 million American men are affected by it. And while prevalence does increase with age, younger men are not immune. When it comes to causes and risk factors, we have quite the list here, and it is not all-inclusive. I just tried to kind of highlight some of the big ones. Smoking, obesity, diabetes mellitus, chronic kidney disease, and certain medications are all very commonly cited causes, and I like to really highlight that medications piece. By some estimates, medications are responsible for up to 25% of cases of erectile dysfunction. And this includes many very commonly prescribed agents, including antidepressants, diuretics, beta blockers, have all been associated with erectile dysfunction. In some cases, it may be hormonal, as in the case of a testosterone deficiency, and erectile dysfunction also commonly results as a kind of byproduct of prostate cancer treatment. Obstructive sleep apnea, having a frequency of intercourse less than once per week, hypertension and hyperlipidemia, as well as metabolic syndrome, some neurological disorders like MS or Parkinson's, and also alcohol and other substance use can be a pretty common culprit here. Particularly drugs like cocaine can be known for having an impact on quality of erection. Relationship issues, understandably, if things aren't going super well, that can affect someone's mindset and the physiological response their body has to sexual stimulation. And we also see a fairly common prevalence of psychogenic causes, things like depression, anxiety, particularly performance anxiety, or a history of trauma or sexual abuse. Now, when we're talking about erectile dysfunction or really any element of sexual health, I think it's really important for primary care providers to remember that it's not just about sex. Sexuality and sexual health is an integral part of holistic health, and there's a lot of information we can get from talking to somebody about issues they're having in their sexual life that relates to many other elements of their whole health. So specifically with respect to erectile dysfunction, per the American Academy of Family Physicians, ED has a positive predictive value for the development of cardiovascular disease that is equal to or greater than that for smoking, hyperlipidemia, or a family history of MI. This is huge. Erectile dysfunction can be a significant red flag for potential further cardiovascular problems down the line. And in fact, erectile dysfunction often appears 2 to 5 years before coronary artery disease, which represents a really amazing opportunity that we have to have a conversation about lifestyle changes and other measures that could both ameliorate the ED that a person's experiencing, but also reduce their risk for more serious problems down the road. ED is associated with an increased risk of angina, MI, strokes and TIA, CHF, and arrhythmias. And the risk of peripheral vascular disease is increased by 75% in men with ED. So by addressing kind of the constellation of factors that contribute to both erectile dysfunction and other forms of cardiovascular disease, we have the potential to make a really positive impact on patients' health and quality of life. So returning to Mr. Barrett, what's our workup going to look like? This stepwise approach to an ED workup is based off of guidelines created by the American Academy of Family Physicians. And it's going to start by using a questionnaire called the International Index of Erectile Function, which is a 5-item inventory that gives you a score to rate the severity of ED symptoms experienced by your patient. You'll want to follow that with a focused history and physical, and then get some labs, particularly a fasting glucose, an A1C, and a lipid panel. And that's because we know that there's a really strong association between ED, diabetes, and hyperlipidemia. Now, if a clear cause or potential etiology for ED is present at this stage, most cases can be managed in the primary care setting. But for cases that don't respond to treatment or for which there isn't an apparent etiology, further specialized testing or consults with urology, endocrinology, or other specialists may be warranted. So let's take a look at Mr. Barrett's workup. His IIEF-5 score is 10, indicating moderate erectile dysfunction. His focused H&P reveals some things we already knew, including his past history of hypertension and hyperlipidemia. His BMI is 30.4, which is just over the line into the obese category. He also endorses smoking 2 packs per day and moderate alcohol use. He denies depression, anxiety, a history of trauma or abuse, or other unusual stressors at this time, and he further denies trouble with his relationship. On a genital exam, he has typical secondary sex characteristics with no unusual findings. When his lab studies come back, we find that his fasting glucose and A1C are in the pre-diabetic range, and that his total cholesterol is also not quite where we'd like it to be. Although his HDL and triglycerides look pretty good, his LDL is on the high side. Now, because we can see he has some clear, known ED risk factors, further testing or specialist consults are not indicated at this time. So, what can we do for Mr. Barrett? Our treatment plan for Mr. Barrett is going to have 3 prongs. First will be lifestyle change, which includes recommending smoking cessation, mild to moderate weight loss, and regular exercise. Obviously, all of these measures have general benefits for overall cardiovascular health and wellness, but they're also known to be of benefit for people experiencing erectile dysfunction. Very closely related to that, we want to manage his risk factors. Some of that can be accomplished through lifestyle change, but some of it's going to mean optimizing his medication treatment for existing comorbidities, including his hypertension and hyperlipidemia. And lastly, we're going to talk about erectile dysfunction medication, the frontline treatment being phosphodiesterase 5 inhibitors. Our treatment goals for Mr. Barrett are to increase his sexual satisfaction by improving the quality and duration of his erections, and also to keep that long game in mind by preventing cardiovascular conditions from developing or worsening. Now, as we turn to a discussion of pharmacological treatments for erectile dysfunction, I think it's helpful to take a moment to review the physiology of how erections actually happen. It starts with the release of nitrous oxide in the corpus cavernosum of the penis. Nitrous oxide activates an enzyme called guanylate cyclase, which then in turn increases the presence of a molecule called cGMP. cGMP is important because it facilitates the relaxation of smooth muscle and results in the inflow of blood necessary for an erection. Another important player to be aware of here is a molecule called phosphodiesterase 5, or PDE5, which breaks down cGMP. Therefore, the more PDE5 hanging around, kind of the more difficult it can be to gain and maintain an erection, because you don't have sufficient cGMP to maintain that smooth muscle relaxation and inflow of blood to the penis. Now, that relationship between PDE5 and CGMP helps explain why PDE5 inhibitors, including sildenafil, also known as VIAGRA, are the first-line treatment for erectile dysfunction. By preventing the breakdown of CGMP, we can help potentiate an erection that is easier to acquire and longer lasting. It's important to note that with these agents, sexual stimulation is still required to produce an erection. It's not like somebody takes a pill and then is aroused whether they want to be or not. And when they do experience sexual stimulation, the process of arousal should feel pretty natural. It should feel pretty much just the same as it would if they were not taking these agents. The half-life of sildenafil specifically is 3 to 5 hours. An advantage of some of the later generation PDE5 inhibitors is that they have a longer half-life and therefore can be taken further in advance of anticipated sexual activity. The initial dosing for Viagra is 50 milligrams once daily as needed, and that can be reduced to 25 milligrams or increased to a maximum of 100 milligrams depending on the patient's response to treatment. For Mr. Barrett today, I would recommend starting at that standard 50 milligram once daily dose and kind of seeing how he does. Common side effects are very similar to those associated with nitrates, which is important for a reason we'll discuss in just a moment. And those include headache, flushing, and dyspepsia. Serious ADRs include sudden hearing loss, vision changes, most commonly what's called blue vision, where the entire world kind of takes on a strange blue tint, sometimes sudden loss of vision, hypotension, priapism, which is an extended or painful erection, MI, and stroke. Now, the use of PDE5 inhibitors, including sildenafil, is absolutely contraindicated with any nitrates or nitroglycerin. And that includes even in patients who maybe take a PDE5 inhibitor early in the day and then experience MI symptoms later. When they arrive at the hospital, we're going to hold that nitroglycerin for up to 48 hours to avoid the potential hypotension that could result from combining those medications. It's also contraindicated with the use of guanylate cyclase stimulators, but that's a fairly rare class of drugs used to treat pulmonary hypertension and doesn't appear as an issue very often. Now, sildenafil does have some interactions. It should be used with caution alongside alpha blockers to avoid hypotension. CYP3A4 inhibitors also can increase exposure to sildenafil. And grapefruit. It's one of those drugs that can be really affected by consumption of grapefruit products. In this case, it can boost blood levels of PDE5 inhibitors, including sildenafil. Now, relative to the specific selection of Viagra for Mr. Barrett, Viagra, it's been around a while. It's available as generic. He did express that cost is a concern. And so looking at GoodRx here in Maine, he could acquire 30 tabs of Viagra for somewhere in the neighborhood of $10 to $20, depending on the pharmacy that he chooses. And it's just kind of been around. It's got a very well-established safety profile. Many providers are comfortable prescribing it. As I mentioned earlier, some of the later generation PDE5 inhibitors have the advantage of a longer half-life and being able to be taken further in advance of sexual activity, but many patients still report pretty high satisfaction with the use of sildenafil, so it seems like a reasonable place to start. So, what does Mr. Barrett need to know about his new medication? I would want Mr. Barrett to know that he should take his new medication at least 30 minutes and ideally about an hour before engaging in sexual activity, though he can take it up to 4 hours prior while still having effectiveness. He should not take more than 1 dose per day. It's also a good idea to take this medication on an empty stomach. Fatty meals and alcohol can delay absorption of the drug, while products containing grapefruit can have an impact in the opposite direction, increasing the body's exposure to sildenafil. So it's probably a good idea to avoid grapefruit-containing products on days you intend to use it. He should also know that it's very important he report to the ER immediately if he should experience any vision changes, heart attack symptoms, hearing problems, or if his erection is painful or lasts longer than 4 hours. In terms of ongoing management, especially given that we're going to be recommending other lifestyle changes and that we want to check back in on those labs related to his lipid panel and his fasting glucose and A1C, I think it's a good idea to see Mr. Barrett back in the office for some check-in and monitoring within the next few months. Thanks so much for listening today. And last but not least, here are some references. Thanks very much.